So now let's get started with today's clinical topic. Our speaker today is Dr. Kevin Suzuki. He practices periodontics and implant dentistry in the Seattle area, and he received his dental degree from Nova Southeastern and his specialty training in perio from Temple University. He's a diplomat of the American Board of Periodontology and the ICOI, and he's also a faculty member at the Resnick Implant Institute. I think this is the fifth time that Dr. Suzuki has been on this webinar. He's always well received. We're excited to bring him back. And last time he started in a big topic and we didn't think he could get all the way through it. But so we decided to bring him back for part two. So here's part two of current guidelines for the diagnosis and treatment of periodontal disease, part two. It's all yours, Dr. Suzuki.
Thank you very much, Neil. Thank you very much, everybody from Glidewell Education. I'm going to share my screen here. And as you mentioned, this was a very large topic to undertake. I was very excited about sharing guidelines and diagnosis and treatment for periodontal disease. And I felt it was important to try and share this topic because I feel like periodontitis is still very much alive in our country and in our world. And the number of cases we're diagnosing and seeing is only increasing. I'm going to give a very brief summary. If any of you missed the part one from last time, all the information that I have here is partly based on the new classification system from the American Academy of Periodontology and the European colleagues, the Federation of Periodontology. There was a collaborative project where they met in Chicago back in 2018. This actually took years of planning. It was a 3-day meeting. They had multiple panels. This is just a summary of all the different diagnoses and updated topics that they addressed. Each one of these boxes does represent a particular committee of periodontists that met, deliberated, and reviewed all of the current literature to update the most current guidelines on each of these. And so I won't spend a lot of time on this since we went over it last time, but just to give you a summary of the updated periodontitis classification system, the colleagues in periodontal medicine and the ADA and dentistry wanted to have a classification system that was similar to our medical colleagues for chronic diseases such as staging and grading of cancer or a really debilitating disease like that. So we wanted to update what we had with our guidelines. So what you're seeing here is the first part of the staging of the new periodontitis disease entity. And you can see there's different criteria here. There's different categories of severity from stage 1 all the way through stage 4. They do base it on clinical parameters that you can see here in the left column. One of the main ones we look at is clinical attachment level. And in this particular designation, they wanted to look at the interdental clinical attachment level of teeth. And so you can see they rate it anywhere from 1 to 5 millimeters or more. In addition to that, you'll also look radiographically at the worst area of clinical bone loss, and you'll make an estimate in terms of a percentage of the amount of bone that's lost on that natural tooth. You can see also we'll look at other complicating factors such as whether they've lost previous teeth or not from a history of periodontal disease. It's not always easy to determine this because the patients aren't always aware of their history of why teeth were extracted. And then they get into other complex factors such as probing depths, and if they start to have multiple furcation involvements or significant rehabilitation needs with occlusal trauma or ridge defects or severe bone atrophy. So that's just a small taste of the staging or the severity of the disease. In addition to that, when appropriate, we'll also assign a grading. Now, this is an assessment of how likely and how quickly the patient is to break down over time. It's not always as easy to designate a grading, and in the classification system, they do admit at the initial exam, you may not have enough history with the patient to be able to assign this. Part of the reason is that they try to base it on the history of bone loss as observed in your practice over time. Of course, we don't always have patients with a history of 5 years or more. And so one of the things they looked at was if you estimate the largest area of bone loss on the worst tooth, and then you observe it over a period of 5 years, they can break it down to no bone loss versus less than 2 millimeters versus greater than 2 millimeters over a 5-year period. Again, that's not always practical. So one of the most common things that I use out of this classification system is a calculation of the worst tooth in the mouth, the greatest amount of bone loss. You'll take that as a percentage, you'll divide it by their age, and you plug it into this range value here. Is either an A grade, a slow rate of progression, a moderate grade B, or a rapid rate of grade C. Now, again, it's pretty involved to do this, and there's a lot to go through with the system, and it's an ongoing thing, right? They changed it after 20 years of not changing it at all. And who knows, in another 10 to 20 years, they might change it again. One other thing that was of note with the new classification system, they had two specific factors: level of smoking and diabetic control. And what you'll notice is that these are in a different column down here, a different category, and they're darker because these trump all other modifiers here of the grading system. So for example, if a patient smokes a pack a day, they're automatically considered a grade C or rapid rate of disease progression. Or if they're an uncontrolled diabetic, such as an A1C value of 7 or more, they're automatically a grade C or rapid rate designation. So I hope that was helpful. For those of you that do want more information on this, it is on the perio.org. That's the Academy of Periodontology website. It is free to all professionals. You can download the original publications or this chart. Also, a brief summary from last time. We did mention some of the designations for when to treatment plan non-surgical care versus surgical care. And I quote back to one of the classic articles from Jan Lindy. A lot of you might have had his textbook in dental school. He initially stated, when we're assessing for patient status and patient periodontal disease, we consider treatment when patients have a threshold of probing depths with attachment loss and inflammation. So patients that have 3 millimeter pocket depths or less, typically we're treatment planning for a prophylaxis, right? We know that if we try to do scaling and root planing, designated here as SRP, will actually cause damage to the periodontal apparatus, will cause a loss of attachment, or the patients will lose attachment. So he designated this threshold a critical probing depth. So again, less than 3 millimeters, if you try to incorporate scaling and root planing, will actually cause damage to the periodontal apparatus. Once you start to get between that 3 to 4 millimeters of pocket depths with signs of disease, there is a significant benefit for non-surgical scaling and root planing. And so that's often when we'll incorporate it with signs of disease present, like erythema, bleeding on probing. However, if we try to attempt resective surgery or pocket reduction surgery, it'll result in a loss of attachment and unnecessary damage or disfigurement, when we know that non-surgical care can be effective. And so that critical probing depth of between 3 to 4 millimeters is beneficial for non-surgical care. Taking it a step further, getting a threshold up to almost 6 millimeters. Here they said 5.5, right? So if you have probing depths of under 6 millimeters with signs of disease, inflammation, bleeding, scaling and root planing is very successful in many of those cases, and it's appropriate to treatment plan first. Surgery, they found, was also successful and helpful in reducing pocket depth and trying to control or treat disease. However, we always like to try to go with the non-invasive treatment first. So according to this threshold, up to 6 millimeters initially evaluating the patient is typically indicated for scaling and root planing when signs of disease are present. Now, once we get to pocket depths of about 6 millimeters or more, this is what we consider the crossover point. So patients that have gone through initial therapy and then report back with a reevaluation assessment of pocket depths of 6 millimeters or more with recurrent signs of disease or bleeding inflammation, that's going to be a situation where now we'll consider resective surgery. They've noted in a lot of the classic literature, pocket depths of 6 or more are anaerobic environments. They're very selective for the periodontally destructive forms of bacteria, like P. gingivalis or Tenorella forsythia. So that was just a general summary there, again, for pocket depths and thresholds, these crossover points. So typically surgery will be recommended 6 millimeters or more when it's not responding to non-surgical care. And so as a general summary, and this is what we often teach at the university programs here, especially the University of Washington, when patients have 1 to 3 millimeter deep pockets, we're treatment planning a prophylaxis. When they have signs of inflammation and pocket depths of 4 to 6 millimeters with attachment loss, we're going to incorporate scaling and root planing initially. We'll then bring them back for a reevaluation somewhere between 4 to 12 weeks. And then if they still present with pockets of 6 millimeters or more with signs of disease, we'll incorporate some type of surgical care. And so that will get us into our options for surgical care. So when we're treating recurrent periodontal disease or non-responsive, we've got some major options here. These are tried and true in the literature. They've been around for a long time. So the first is resective surgery, or what we've often heard of as osseous pocket reduction surgery. We consider it a subtractive technique in the respect that we're actually removing some of the diseased tissue, we're recontouring bone, subtractive or resective. We're removing some of the diseased tissue around that crevicular area. We also incorporate regenerative situations or regenerative biologics when appropriate. So for this cartoon illustration on the right side here, we might incorporate things like bone grafts or membranes to actually attempt to regenerate back some of the periodontal apparatus, some of the bone, some of the periodontal ligament. Even redeposition of cementum is sometimes possible. And then one of the newer emerging techniques out there would be the incorporation of some type of laser technology. So this is a hybrid approach of both pocket reduction techniques and sometimes seeing some regenerative benefits. And so one of the common techniques that's quite popular out there is called a LANAP, or the laser assisted new attachment procedure technique. This is a trademarked technique I'm most familiar with for my surgical training, and I'll share a little bit about what we're incorporating in our practice and the results that we're seeing there. So to start very briefly with osseous resective surgery, and this is somewhat of a review from what I showed last time, the purpose traditionally was to remove the diseased and inflamed crevicular tissue around the natural teeth to allow for a clean surface for healthy tissue to reattach or readapt to those root surfaces. So we'll reflect these full thickness flaps to gain access to the root surfaces and the underlying bone. We'll be able to directly scale and root plane and mechanically debride those root surfaces, creating a biologically compatible environment. We'll also recontour the bone to create a physiologic environment so that it can readapt to the teeth most appropriately and create a situation that's more maintainable by the patient for better hygiene access. Once the bone has been recontoured, we tend to festoon the architecture of the bone, similar to when we had to do traditional dentures with wax. We had to festoon the wax to look physiologic back in dental school. Then we'll reposition the flap, typically in an apical position, so that we can create this biologically compatible environment and reduce that anaerobic environment. And so for a situation clinically like this, where a patient's been diagnosed with periodontal pockets and disease, the whole goal is to allow direct access and visibility to be able to remove these biological contaminants, to create an aseptic environment so the body has now a favorable healing situation. And so when we're doing resective surgery, or this subtractive technique, when we reflect a periodontal flap, we consider a clinical situation here. We can either reposition the flap at one of three situations. We can reposition at the same level where it was removed from. We call it a replaced or repositioned flap. We can put it at a higher level on the tooth, depending on your frame of reference, or coronally advancing the flap. This is typically reserved for things like gingival augmentation or root coverage for connective tissue grafts, or for pocket reduction or pocket resective or osseous resective surgery. We often put the flap at an apically position or a lower level along the tooth. So if we were to show you what the bony architecture looked like in a clinical situation like this, a replaced flap would go back to the same position right at the embrasure spaces. We try to put the papilla right back where they were. Often, if we're just reflecting the flap, to do what's called an open flap debridement, just to gain access to remove calculus or remnant abscess material. The situation, as I talked about, for root coverage or maybe augmentation, such as a coronally advanced flap, is typically placed at the higher level on the tooth. So on our diagram showing the underlying bone, a situation like this, coronally advancing it. Or for pocket reduction surgery, an apically positioned flap at a lower level on the tooth. So again, there's going to be more bone removed, there's going to be more of the tooth showing, and the embrasure spaces will obviously be larger when you have a lower level. So this is a perfect example of showing that. And this is giving credit back to my practice partner, Dr. Thomas Kang, here in Washington with me. This was a thing that we had observed and noted, and periodontists, throughout time have noticed that when we do the resective surgery, the unfortunate consequence of that is that the patient does have these larger embrasure spaces. They'll often get increased temperature sensitivity. They'll often also experience that when they eat food, it tends to collect a lot more easily in between some of these embrasure spaces, especially in the posterior. And so, there's a significant disadvantage and a disfigurement that comes with that. And so we coined this term in our practice, the disfigurement and undertreatment conundrum. And basically this problem that we're describing is that when a patient's faced with a tough situation to treat disease and then be suffering the consequences afterwards of this disfigurement, sometimes they might be set with decision paralysis, where now they don't want to move forward. The problem with them not wanting to move forward with treatment is now also we're participating in a form of sometimes supervised neglect, right? We just continue their maintenances. We say, well, let's see you again in 3 months. We'll try to continue to do the best we can, and you do your best at home, but they're still breaking down. And so this was a frustrating situation we faced clinically that motivated us to try and look into some additional options. This is a perfect example as well here, showing immediately after surgery on this lower here. This is a left and right picture here. Here's Dr. Kang's case up here. This is just showing the significant and stark contrast to when you start initially before pocket reduction surgery, and then immediately afterwards once you've removed those bony defects. Now, as an alternative to resective surgery, sometimes in very appropriate case selection situations, we can incorporate regenerative biologics. Now, this is a traditional periodontal technique for very contained bony defects that had multiple walls of bone left or appropriate blood supply. Typically, once you can access and clean out this contained bony defect, remove all of the diseased tissue, we'll then place a biologic barrier called a membrane. This is also called guided tissue regeneration because of the purpose of placing this membrane to help stimulate and regenerate back several different types of tissue around this tooth. And I'll show you in a moment what I mean by that. So we originally, though, would use these non-absorbing barriers. Nowadays, we have both resorbing and non-resorbing options to place into that area. And the purpose would be to contain that cleaned out and decontaminated defect. You'd lay the soft tissue back over top, sometimes even coronally advanced. And that would allow all of the various periodontal tissues around that defect to regenerate and grow back. So we would see hard tissue or osseous architecture. The osteoblasts and clasts would be active at producing and laying down new bone. In addition to that, we'd see new periodontal ligament laid down between the bone and the root surface. And then surprisingly, what some might not expect was we would also oftentimes see a redeposition of cementum on the root surface of the tooth. So you're actually getting 3 different types of tissue. And this is the reason why they called it guided tissue regeneration, because we're not just gaining bone, but also the other supporting tissues in that site. And so again, for very specific defects with multiple bony walls, we can incorporate these barrier membranes. In addition to that, we would also incorporate bone augmentation materials or bone grafts. This is a chart showing the 4 categories of bone grafts that we use in our profession currently, and also they use often in orthopedic surgery with our medical colleagues. But considering this chart from top to bottom, and there's an arrow showing the order of preference when these grafts are preferred to be used or when the ideal situation is to use them. Now, we've often thought of autografts or bone that comes from the same person that can be harvested as the gold standard. It has vital bone cells, regenerative capabilities. It's got morphogenetic proteins and all kinds of other growth factors present to help for a really robust regenerative response. We do know it comes at the cost of secondary surgery sites and increased morbidity afterwards or patient discomfort. So recovery can be significantly altered by having more surgery sites. So it's often now incorporated and more commonly accepted to consider an allograft option. This is bone that's been harvested and used in a biologics company from organ donors. So it's human derived, it comes from the same species. And we'll use this graft in conjunction with barrier membranes. They also have really great regenerative potential, but we do know that there's no vital cells in that material. It does tend to induce the body's cells like the osteoblasts and clasts and the osteoprogenitor cells from the adjacent vasculature to migrate into that site, consume this material, and turn it over into new bone. So after 3, 4, sometimes 5 months, this graft material is completely turned over into healthy human supportive bone around natural teeth. And now we're using it very commonly for dental implant procedures. A third category, in slightly lower down on our spectrum here, would be the xenograft. These are bone graft materials that are harvested from and derived from animal sources. The 3 current FDA-approved categories of xenografts come from a cow, a pig, or a horse in the United States. And these are considered alternatives. You might have certain individuals for whatever religious or personal reasons or cultural reasons may not want to go with a human-derived option. So these are also considered acceptable and do have regenerative potential. We have found that they do take quite a bit longer to turn over and cause regeneration in some situations. So that's our third category, the xenograft, or animal or another species derived. And then our fourth category is a synthetic or lab fabricated graft materials called alloplasts. These are fabricated in a laboratory by biologics companies. They do have some regenerative potential, but they're not human derived. And so the growth potential and the regenerative potential from these is somewhat less. Some of the things that we have seen with these synthetic materials is that they don't always necessarily have complete turnover over a long period of time. So for that reason, we don't necessarily always want to use these around natural teeth. Sometimes I'd reserve these in my practice for situations where a patient might get a tooth removed, but not want to progress with an implant. So for example, maybe to support underneath a pontic of a bridge or a complete denture or a partial denture. So those again are the four categories there in order of preference, from autograft to allograft to xenograft to alloplast. So this is showing a case example here of guided tissue regeneration now around a natural tooth. So we have our diagnosed periodontal defect here. This is a probe showing the defect as it's probably at least a grade 2 furcation, probably 5 to 6 millimeters deep. You can see it's probably also somewhat associated with that restoration that went partly subgingival there, a very large overhang. So once we reflected a full thickness flap, allowed access to clean out that furcation there, debriding with curettes, irrigation, maybe ultrasonics, will then allow us the opportunity to try and contain that. Now, in this particular example, they're showing just a barrier membrane applied here. If you were to lift that barrier membrane up, we would have put in bone graft underneath there. You can also see a hint that they've recontoured and adjusted some of the restorative margin of that restoration there to try and remove that overhang. So we're mechanically altering that environment to make it less selective for anaerobic bacteria. We're cleaning it out and decontaminating it, placing a regenerative, biologically potent regenerative agent there, and then placing a barrier membrane to exclude the epithelium from migrating into that site to allow for that bone regeneration to occur. Once it's repositioned or sometimes coronally advanced, then it's sutured into place and secured, allowed to heal for a minimum of 3, 4, sometimes up to 6 months. Now you can see here during the healing, there has been some tissue loss, but in the greater good of things, we've actually been able to fill in that furcation with some bone fill and reduce that pocket depth. So for this particular case study from this publication here from Caring and Lindy's group, they re-entered the site after several months and showed that that furcation had indeed decreased in depth. There had been some bone fill there. And the second surgery was just for the purpose of removing the membrane and then also documenting that site. So we do see in select cases where you have good contained defects that can be appropriately decontaminated and made biologically compatible, regeneration can be possible. So here's our preoperative view. There's the postoperative view showing the potential for some of that bone fill and regeneration. Now, this is one of my personal cases showing another example of this guided tissue regeneration. This was a 61-year-old patient with some cardiac controlled issues. You can see if we just look at the very localized charting on this one tooth here, this is the lateral incisor that was serving as a pure abutment tooth, excuse me, for a fixed bridge. You can see evidence of a very significant angular defect here. It was quite severe. We had pocket depths and attachment loss of up to 9 millimeters in these cases. There was also bleeding and some suppuration there. So the patient had gone through scaling and root planing in an attempt to non-surgically improve the site. And then at the reevaluation, these were the conditions that we found. So this patient was treatment planned for an exploratory surgery with the purpose of providing regeneration to that site. So what we'll do is we show the pocket depths there, the radiograph. Here we're showing our surgical flap reflection. We extended at least 1 to 2 teeth of a full thickness flap to either side of that defect area. You can see the very significant evidence of angular bone loss. There's also loss of some buccal plate in this situation here. So we're able to decontaminate that area. I tried to show a little bit of a view from the palatal. Of course, it's a lot more difficult to get a good photograph from here, but you can also see some evidence of part of that defect wrapping around the tooth here. Now, some of you might be seeing this and saying, well, you know, with this much bone loss, maybe it might have been better to consider, you know, just outright extracting the tooth and developing it for a dental implant. And I can assure you that was actually a conversation that we had. So this was only after the insistence of the patient. He absolutely wanted to do everything possible to try to rehabilitate this site. He was adamant about not getting the tooth removed. You also see some evidence here of us checking and adjusting occlusion. We wanted to actually, when we're trying to gain regeneration, we would adjust these sites to remove that offending tooth out of the occlusal plane to allow for the best chance for stability. Once we decontaminated that site, irrigated out with sterile saline, removed all the etiology from the root surface, then we placed a combination of bone graft material here. Now, I like a combination of freeze-dried bone allograft that's cortical and cancellous. Some clinicians like demineralized bone graft. From an ideal world, you would actually incorporate probably a little bit of both to take advantage of both of those principles there. In terms of the products that I use, some of the great products we have come from Newport Biologics. There's also regenerative products that come from BioHorizons, Nobel, Zimmer. Probably many of you are familiar with others. And so here we place that particulate graft material hydrated in sterile saline or sterile IV antibiotics to decontaminate that area into that defect. You can see we're basically, for the purpose of reconstructing all that lost bony architecture, I then pre-shaped and cut the barrier membrane to wrap over top of that defect site. There you can see what it looks like. We kind of made like a saddle or almost like a horseshoe shape to wrap around the defect. And again, the whole purpose is to prevent that faster growing, faster migrating epithelium from migrating into that defect site and consuming and breaking down the bone graft. Healing is always a race between hard tissue and soft tissue. And without our assistance with biologics like this, the soft tissue always wins. So that's the reason why these biologics can work when allowed to contain that space appropriately. This was showing us re-advancing, and in actually the case of the lateral incisor, coronally advancing the flap here on top of those regenerative materials and securing with sutures. And then we also repaired a vertical release incision back here, which was placed for access and visibility. So here's our initial preoperative state there. Then we're showing our immediately post-operative film with what it looked like with the bone graft placed. And we, again, would take another film 6 to 9 months later to verify that there is indeed still bone support there and that the bone graft is turned over. Fortunately, after 6 months, and this might have been a little bit soon to probe, but I was excited about finding a result. The patient was looking great with their healing. We did find some pocket depth reductions of up to 4 or 5 millimeters in these sites. And we were actually getting hard and soft tissue regeneration and reattachment to that tooth. We also checked the occlusion multiple times throughout their follow-up. And in this case here, so far, he's still a patient of record with us for maintenance. So that's showing our regenerative options or guided tissue regeneration. Well, what's the third alternative? Well, we talked about the possibility for laser incorporation. And so I present to you one of the techniques we're using very commonly in our office. It's called the LANAP technique, the laser assisted new attachment procedure. This is a trademarked periodontal treatment, and it's trademarked. It's approved by the Food and Drug Administration to be incorporated in the technique according to what I'm going to show you stepwise here. And this is using an ND-YAG laser. That's a neodymium yttrium aluminum garnet laser. So it's really a soft tissue laser that's been specifically approved for this protocol. There are different families of lasers out there. And for those of you that use other forms, I would just encourage you to check the FDA approval for which procedures are appropriate for the technology that you have. And of course, the reps that work with you and sell you these technologies and these lasers should be familiar with that and be able to offer trainings. So this particular trademarked protocol was designed to use or take advantage of this harnessed laser energy. It goes through a fiber from the laser to a filament. And this filament is contained often in a little cannula, or almost what we call a handpiece cannula, such as this. So when you insert this little cannula that's about the diameter of a periodontal probe into the gingival crevice, this picture over here on the right side shows that the purpose is to incorporate that laser energy. It spreads out into all directions to basically decontaminate and kill that bacteria in the site, to disinfect the area or decontaminate it, to make it more biologically compatible. So for example, the steps of this LANAP protocol for periodontal disease would be to diagnose our periodontal defect first. And you can see here in this cartoon illustration, the side of a root surface with our etiologic deposit. It's a very deep defect with an anaerobic environment. There's also been loss of bone, loss of attachment. So the initial pass with this laser is designed to emulate and replace the scalpel blade. So instead of resecting tissue and cutting it away with a scalpel, now the laser energy spreads out in all directions. It penetrates deep into the crevice. We insert the fiber to the deepest point of every square millimeter of every degree circumferentially around the tooth. And then we activate the laser and it spreads out to be absorbed by and kill all these darkly staining or darkly pigmented periodontal pathogens. It also spreads out into the heavily engorged vascular tissue when it's inflamed, and it's absorbed very readily by the diseased and dead tissue, while leaving the healthy tissue alone. And so this is our resective step. Then we'll re-enter that site now that we've technically reflected our flap with this resective laser step. With this particular trademark technique, we use a series of piezo instrument tips with irrigation of sterile saline mixed with Paradex or chlorhexidine or some type of cationic detergent, so chlorhexidine. And the purpose is to mechanically debride the root surface to remove all of that bacterial and calculus deposits to make it biologically compatible, and then also irrigate those debris and that contaminant out of that sulcular site with the irrigant, the chlorhexidine sterile water or sterile saline. So we've done our mechanical debridement, and then we'll go back with the laser a second time on a different setting. So now we have this hemostatic or coagulation setting. Right, the purpose of hemostasis is to reestablish this biologic seal or a biologic clot to fill that area. And the fortunate thing about this is that we no longer need sutures for this pocket reduction technique. Because we form that biologic seal there, we'll then do some compression with gauze for a few moments to minimize the thickness of that clot and encourage readaptation of that soft tissue lining circumferentially around all the teeth treated in the quadrant. We also incorporate a very generous, robust occlusal adjustment or occlusal equilibration of that area of the mouth that we're treating. And so the LANAP protocol is designed to be a full mouth protocol. It's designed for patients with generalized periodontal disease, and we call it LANAP. It's trademarked for full mouth. You can treat specific areas and just a specific tooth even, but you have to call it something else. You can't call it LANAP. So again, LANAP is a trademarked protocol for full mouth disinfection treatment. So with the occlusal reduction or occlusal adjustment, it's typically designed to adjust all the teeth in the mouth except for the canines out of occlusion initially when they're healing. And I know that can sound a bit kind of liberal or aggressive to some clinicians because we think about, well, if we grind all the teeth down, that's a very significant change. And yes, that is true. It is a significant change, but the extrusion of teeth over time as they're healing is one of the major factors that this technique is also allowed to work, in addition to the biologic potential of the laser technology and the decontamination. So we do want to see extrusion of teeth over time to hopefully promote reattachment and regeneration, such as this diagram shows here. So this is just a proof of principle showing a video. If we were to harvest these periodontal pathogens from a patient from their crevice, put them on a microscopic slide, this is typically what that gram-negative anaerobes would look like, those rods and spirochetes. And this is provided from courtesy of the Millennium Dental Company, the trademark of the LANAP technique. This is Dr. Jin Kim showing in his laboratory that harvested bacteria. What he's doing is subjecting that slide to this Nd:YAG laser wavelength technology. They operate at a wavelength of 1064 nanometers. And on these settings, he's subjecting the bacteria on that slide to the typical amount of time it would take to treat about 2 to 3 teeth in the mouth. Then what you're seeing is as he's going to go back into our slide, showing that vital bacteria that was just moving around and swimming you saw just a few seconds ago. Once it's been absorbing all this laser energy, has had a chance to work, you can see all of the bacteria has basically been destroyed and killed. All we see are floating, components and proteins and, some of the structures now that have been lysed out of the bacteria. There's no biofilm left there. So that's the principle, and the benefit of this is we're decontaminating the area and we're leaving the healthy tissue alone. So that's just a proof of principle kind of showing what a typical situation would look like. And just in case my video didn't come through clearly over the Zoom podcast here, I was just showing some of the before, during, and after images here where we're showing that vital, darkly staining bacteria here was swimming around and moving, once subjected to that laser therapy for just a few seconds. Then we're showing afterwards all of that bacteria has been destroyed. And so that's the benefit of the laser technology for decontamination. This video was provided courtesy of my father, who I'm very proud of to be able to work with and collaborate on a great deal for meetings and lectures. Dr. John Suzuki. Here he's showing at his practice in the VA hospital the incorporation of this LANAP technique. Now, this patient is under IV sedation. However, most of the patients can undergo this with just local anesthetic. Here you're seeing the first pass with that laser initially. And I'm going to try and turn that sound down to spare us the unpleasantries of that piezo unit there. So he's gone through that first pass, that resective part. Then he's got access to go back through now with various piezo tips with that irrigation for the mechanical debridement. You can see bits of calculus and etiology coming out of those sites. And we'll decontaminate every single tooth, every square millimeter, all the way down to the base of the pocket. In addition to that, he's also going to score the bone to promote angiogenesis. After the decontamination, we'll go back for that second pass with the laser on a different setting now for the hemostasis step. And this is what we were talking about, that biologic seal. This is the benefit of now creating that seal so you don't need sutures. So it will have great biologic potential for regeneration with that clot there. So again, if the video unfortunately did not come out as clear as we would like on the Zoom, I just had a couple of pictures illustrating those steps here. This is one of my cases showing, in the anterior, we're going to do the resective laser first pass circumferentially around each tooth. You can see the biofilm here initially. So we would insert that crevice around every aspect of the tooth to decontaminate. Then we'll go in with various piezo instruments with our irrigation to mechanically debride that area. We'll then enter a second time with the hemostasis setting for that biologic seal. This is what the tissue typically looks like immediately after that hemostasis setting. Sometimes there's a little bit of a clot visible around the teeth. We then talked about doing a very generous and robust occlusal adjustment on all the offending teeth in the diseased sites. And then afterwards, hopefully we'll see some regeneration. So let's show you a couple of live examples from my practice. Now, I'm not going to draw your attention to every single number here on the charting, but what I can tell you about this patient is that she was a pack-a-day smoker. She was a 50-year-old female, originally from South America, that came to Seattle. She came to my practice with generalized advanced periodontal disease, pocket depths with attachment loss, generally to most of the teeth of anywhere from 5 to 9 millimeters or more. Now, some particular areas from the radiographs you can see here, if you look at that right canine, that number 6, you also that lateral incisor number 7, those had very, very severe bone loss. That number 7, I was almost sure that there was no way I was going to be able to save it. And we talked about the eventual conclusion of probably having to extract it. So just with the initial treatment of this Lanap technique of the entire mouth, we saw an average of pocket depth reduction of about 50% or more in the majority of sites. We're talking 3, 4, up to 6 millimeters of pocket depth improvement and some reattachment. Now, I know it's harder to see the numbers, but let me show you the radiographic results that we can see here. So that picture on the left side is showing what she looked like preoperatively. There was some fibrosis to the tissue. If you look in the lower anterior area, that tissue is real flaccid and kind of flimsy. There was some cyanosis there. This is what she looked like after she left one appointment of one side of the mouth with a Lanap procedure that typically takes about 90 minutes to do half of the mouth, 90 minutes to 2 hours under local anesthetic. And then when she came back 6 months later after complete treatment, you can see there's a significant change in the tissue tone and color. You can see if you look at the gingival margin here of that number 9, you can see there's been some firming up of the tissue there. If you look at that flaccid edematous tissue here on the lower anteriors, it almost looks like we did a keratinized graft there, which I assure you we did not, but the tissue has gotten firmer and stippling has shown up there. Also, if you look at the preoperative film, some of the worst teeth in the mouth here was showing those lower anteriors. Remember that lateral and that canine we talked about? Just within about 14 months, we took new radiographs. You can see there was very significant regenerative potential here, where this tooth I would have otherwise extracted now has a fighting chance with some regeneration around it. Here on the lower central incisors, you can see that there's not quite as impressive a regeneration. However, we do have a return of some lamina dura. The PDL space is intact. You can see we've gotten some bone growth there. And you can also see some evidence of some splinting that we incorporated as well. That can be a significant part of treatment, is splinting or occlusal guards, or sometimes both. So we have to be able to create a situation of some periodontal stability here, which she was very grateful for, that she didn't have to get any teeth removed. And she's still a patient in ongoing maintenance with us. We'll typically see these patients every 3 months. And when they're referred to us from a private practitioner in our periodontal office, we see them about every 3 months for the first year. We'll then do a comprehensive reevaluation at about the 12-month mark. And then we can make a decision about whether to recommend referring them back to the general dentist, maybe co-maintaining, alternating every other 3 months, or maybe keeping them in our practice if they're not responding well. This is just one other case abbreviated here, showing you some specific sites. And I'll draw your attention very specifically to this first molar on the lower there. You can see that severe angular defect. There was bone loss there with pocketing of 11, 12 millimeters. Just after undergoing this technique, about a year and a half later, we saw some very significant regenerative potential, specifically in this area. There was also some regeneration on the upper molars. However, you can't see it as well radiographically. But the pocket depths spoke for themselves: 4, 5, 6 millimeters of regeneration and reattachment. So just some radiographic signs there. And in the last 5 to 10 minutes or so, as promised, I did want to incorporate and talk about maintenance. And typically what we're teaching at the University of Washington right now, for patients that have undergone initial or surgical therapy, we might consider putting them on maintenance every 4 to 6 months if they satisfy the following criteria: pocket depths of about 4 millimeters or less, if there is inflammation present, but the cause is very obvious and apparent, so we know it's controllable. So these are patients typically that can be seen a little bit more or less frequent maintenance if we know it's controllable. Now, we typically want to see them more often, such as every 3 months if they have pocket depths of 5 millimeters or more, but perhaps minimal bleeding on probing, which means there's no signs of disease activity. So that would be every 3 months. So, again, we harken back to that threshold of that 6 millimeters or more of a signs of recurrent disease activity. If we start to see continued inflammation, deeper pockets, or increasing depths, we want to formulate a new treatment plan, possibly consider surgical care or referring to a surgical specialist. In terms of maintenance, some of the classic literature from T.G. Wilson's group, he also was famous for publishing a lot on cement implant complications. He did a study in some of the academic settings and clinics where they tried to evaluate, what percentage of patients at that time were considered compliant versus non-compliant. Now, in the academic setting at the schools he was working at the time, he found that only about 16% of patients were completely compliant with the intervals and how often they were supposed to come back with the home care. The vast majority, almost 50% of patients, were considered erratic compliers, meaning they'd miss maybe every other or several of their maintenance appointments per year. Maybe they weren't great about keeping a positive plaque control score of less than 20%. Maybe they weren't flossing. And so we all see this in our practice, probably with even higher incidence than 50%. And then he found that about 30% of the patients in that population were, non-compliant. They just wouldn't show up or, didn't do any of the things they recommended for home care. So the idea of maintenance in general would be, we do our best attempts to try to customize the intervals and how long we spend with the patient at each of their visits. We can incorporate up to 4 times a year or more. Traditionally in dental school, we taught, 6 months, 4 months or 3-month maintenance intervals, but it could be appropriate to see patients more often. Maybe they're immunocompromised, or maybe they're undergoing cancer therapy. Or, for example, one of my professors in dental school was a hygienist before she was a periodontist. She had a judge as a patient, and that patient refused to brush his teeth. So his maintenance interval was every week. He came every Friday, would read the newspaper while she had to scale all the bits of bacon and things out of his teeth. And so, it's also important for us to remember as clinicians, when we treatment plan and make recommendations, we don't want to get in the habit of being insurance-based. And I know Dr. Levin can offer a lot more guidance on this as well in terms of scripting and dialogue and support. But we want to get in the habit of not just limiting ourselves from a negative standpoint, saying, well, your insurance only covers this 4 times a year. Rather, would you like to control your disease, Mrs. Jones? Well, in order to do that, we really need to see you more often, maybe 4, maybe 5 times a year. And so that's the recommendation we have. So some of the things that have traditionally been suggested to try to increase compliance would be to try to make the appointment before the patient leaves the office, try to give them updated notifications. Of course, we used to do the old-fashioned postcards and mailers. Now I've got these great email and text notification reminders. Unfortunately, we find that a lot of people still don't check their text updates, but, as multiple points of contact as we can possibly produce for the patient that they'll allow us to incorporate to help them. And then, of course, having a specific discussion about the consequences of not treating or not appropriately maintaining, right? You're going to have disease breakdown, Mrs. Jones. If we don't treat this and we don't see you enough, or we're not doing enough to incorporate controlling the disease, you could lose teeth. It's a very significant reality. So a couple of other things that we can incorporate with home care for the patient, we're very familiar with many of these, in addition to just toothbrushing and flossing, interdental brushes can be a great motivator and a great way for patients to really incorporate interproximal home care, because that, you're only telling half the story if you brush the teeth. You only get the front, the back, and the tops. You need to do something in between the teeth as well. And this plaque score picture here, provided by Dr. Francis Serio, a periodontist and mentor I respect very much, shows the evidence of plaque score when patients are not compliant. Right. In addition to that, what we're seeing is that there's a lot of evidence now to support that powered brushes, such as these ultrasonics and even these rotary oscillating brushes, are much more effective with patients' compliance than with manual toothbrushes. We'll actually see a significant reduction in plaque score, gingival index, bleeding indices. These toothbrushes, they're so great now, they've got technology we can attach to our phones with Bluetooth to tell us when we've missed surfaces of our teeth and how compliant we're being. In addition to that, just more studies here showing that sonic brushes and even rotary oscillating brushes are much better than those standard manual toothbrushes. One of the studies I also like to share is that we're seeing that if you rank interproximal methods of home care, we're actually seeing much greater compliance and effectiveness with these interdental oral irrigators, such as Waterpik or Water Flosser, or some brands that I like. So they have these pressurized jets of water that can go not just interproximal, but also subgingival for our high-risk periodontal patients. We're also seeing that the interdental brushes, such as you see here, are quite effective at allowing for patient compliance because they can do it with just one hand. Now, to supplement that, we can also use antimicrobials. You're very familiar with these common FDA-approved over-the-counter rinses, such as phenol rinses like Listerine, acetylpyridinium chloride like Crest Pro Health, which has a substantivity of about 12 hours, and then chlorhexidine as well, which we traditionally prescribed, has a substantivity of about 12 hours. Listerine, the phenol-based rinses, have a substantivity of about 30 minutes for killing bacteria in the mouth after use. Now, in addition to that, and I always get jokes about this, but we're seeing that in periodontal literature, it's been around for almost 60 years or more, we've seen really great results with dilute sodium hypochlorite solutions as well. And I'll just go for about 2 more minutes, and then I want to be available for a few questions. But if you dilute about 2 teaspoons of hypochlorite, that's traditional bleach, in a large volume of 8 ounces of water, the patient can rinse with this as an alternative to some of these other rinses. More importantly than that, they can also be incorporated into this oral irrigator or water pick, where you can use this dilute bleach solution. And this is our first go-to with all of our periodontal patients now, where you can use this dilute solution in the water pick to irrigate subgingivally to help control that biofilm. You could also incorporate a mixture of Crest Pro Health or CPC rinses or chlorhexidine. I used to advocate for Listerine, but one of the most recent dental meetings I went to, these phenol rinses, the engineer of the water pick actually told me don't use phenol rinses because they break down the O-rings faster. And we can see this interproximal, agents like Superfloss or interproximal brushes will actually incorporate this antibacterial solution on the interproximal brushes or Superfloss, and we can get better access in between these areas. And this has been published by, Dr. John Suzuki and Dr. Bronstein in the Contemporary Implant Dentistry textbook. And we're also seeing other papers that suggest this could be very valuable as well for intraproximal supplementation. So that's pretty much all the time I have. The last thing I just want to show as a point going out, people have asked me about oil pulling. It is the ADA's position that oil pulling is not necessarily an effective way to control plaque biofilm successfully. You have to do it for a minimum of 20 minutes in order for it to even create a benefit. And so I'd rather have the patient brush their teeth and use a water pick for about 6 to 7 minutes than that. Tongue scrapers can be a good supplement, but we don't have a lot of research yet with periodontal disease, but they can be a great way to reduce biofilm from the tongue. And then the last one I'll leave you with here would be my slide on what's safe and not safe to use on dental implants. So typically we've thought of metallic and ultrasonic scalar tips that are metal, not safe for implants. Stainless steel instruments can gouge implants. We know that ultrasonic with protective sleeves are safe on implant surfaces. Air polishers, we see really great things with products like ProfiJet with glycine paste is very effective, and non-metallic scalars like plastic or graphite or titanium. So thank you very much for your time. I'll leave you with my email here. I welcome direct questions, and I'd be happy to stick around for a few moments afterwards, just in case.
Well, thank you, Dr. Suzuki. It's been a while since I've seen a periodontal lecture that covers as much a scope of you do and really brings us up to speed. So thank you very, very much. We've got a lot of questions here, and I think the questions they're excellent. It'll be a great discussion. So if we want to stay around another half hour, if you have time, we'll go ahead and we'll add 30 minutes onto our CEUs for the program. And let's just go ahead. Is that okay with you, Nicole?
Yes, I was just going to say I can update that.
Yeah, let's update that. So Kevin, I've got a bunch of questions here. So first about these new classifications, are insurance companies using these new periodontal classification systems to adjudicate the claims, and are they rejecting claims using the older system?
So I appreciate you asking that. I did try to verify this. Actually, I've been giving this lecture for quite a few years, this material, and I've been updating it. About a year and a half ago, I did send an email out to one of the contacts here in Delta Dental of Washington asking that very question. And he responded back at that time that they still were not planning on using it anytime in the near future with these updated classification systems. They still use the original, grading system that we were used to for case classification. So again, that was a year and a half ago. It's possible things have changed, but I'm going to guess that probably they're still not using it yet.
I mean, this system was promulgated in 2017, I believe. So, it's 6 years and they haven't caught up. That's interesting. Okay, about your GTR cases. Question is, does GTR work with endodontically treated teeth as well as it does with vital teeth?
So I would say that part of it is heavily dependent on the morphology of the defect. And what I mean by that is you have to look at the number of bony walls. With endodontic lesions, we see some situations where they treat a combined endodontic periodontic lesion. They typically recommend treating the endodontic lesion first, and then the periodontal lesion can go on to do the surgery. So, if you have 3 or 4 bony walls of support there, I would say it's much more predictable. If you only have 1 or 2 bony walls of osseous architecture left, it's going to be much less predictable. So, it depends on the morphology, and, case selection is everything. So that's the most I can add about that. So typically, yes, it can be predictable if you have enough bony support left.
So that's what case selection is all about, right? Is how many bony walls do you have? And I imagine a furcation, they're not exactly bony walls, but they're hard tissue walls, right? That's a more enclosed type of area to graft. Any contraindications that you can think of offhand where, hey, don't try GTR in this situation? What about, let's say, a buccal wall that's missing?
You said a buccal wall is missing.
Yeah.
So, if there is some containing wall kind of supplementing I'd say the mesial or distal, then maybe it could be worthwhile. But typically just to replace a buccal plate around the tooth is not always very predictable. And so I typically shy away from doing that. The other thing, of course, would be horizontal bone loss, just straight across the board. You're never going to see a gain in bone height around natural teeth with graft like that.
Right. You're just never going to get a vertical bone growth. Exactly. And then how do you treat the root or the tooth surface in these GTR procedures?
So some of the ways you might think of for mechanical debridement, so we'll do a combination of ultrasonic scalers, traditional hand scalers. Some of the things we do in our practice, and other periodontists do this as well, is the surgeon will reflect the flap, they'll leave the room and start another case, and the hygienist will come in. I can't tell you how many hygienists, when they're involved, they love the direct access and visibility and being able to mechanically debride it out with direct vision. So,
okay. And do you ever use any chemical or acid preparation of the structure prior to GTR?
So there's been some literature by Mariotti's group. He actually did a regenerative study showing if you use things like EDTA or citric acid, other things like antibiotics and root preparation agents, there really wasn't much of a difference, although some surgeons swear by them because you're removing that biologic smear layer. So me personally, I don't use any kind of root preparation agents, but I do irrigate really thoroughly after the mechanical debridement. So.
Okay. Can you comment on the use of Emdogain in GTR?
Yes. So in terms of biologic, this is an exception to that question. Emdogain is a biologic product. I think it's still manufactured by Straumann. It's called enamel matrix derivative. It's originally derived from the stem cells that, remember, the Hertwig's epithelial root sheath that we learned about in histology a long time ago from pigs. So it's a porcine-derived regenerative product that's designed to be used in periodontal defects. And it's the purpose is to actually promote this migration of the osteoprogenitor cells from the blood vessels into this defect area to promote regeneration and reattachment. So it's FDA approved for periodontal defects. It's designed to be used after you mechanically decontaminate the root. Then you'll use EDTA to treat the root surface. You'll irrigate it away and then apply the Emdogain and leave it in that site.
Okay. I have an interesting question here. One of the doctors wants to know, how do I explain the use of Emdogain to my patient?
Yeah, so we call Emdogain a biologic modifier or a biologic, regenerative agent. So it is a product that's FDA approved specifically for periodontal disease defects. I would tell them that it's to promote growth and regeneration as a supplement to the other products that we're using. And it's designed to be left in place, and then the body will use it to turn over the bone, and the product will completely diminish after it's done its effect.
Excellent. Excellent. Okay, here's a question from somebody that's probably my generation that remembers when the AAP was very much against the use of lasers. And so can you discuss the AAP stance on lasers? Obviously, periodontists are using lasers every day now.
Right. And I'll admit it is still controversial, right? It's so polarizing, just like many things these days, right? Charlie Cobb was the periodontist that published that position paper back in 2011. And there was no love for lasers at the time. He said they don't really be shown at that time to work better than lasers, better than traditional surgery. He didn't think there was much of a significant benefit. Since then, Charlie Cobb himself, actually with his group, has republished a newer updated statement, some of the regenerative J. Perio articles showing that now lasers are somewhat considered almost a first line of therapy because of their minimally invasive nature, their low costs, and they're actually seeing some benefit to those. So, I would have never expected that back in 2011 when I started my residency.
Yeah. Well, in the early 2000s at the ADA meeting, one of the laser companies put up a giant banner that said, buy a laser and fire your periodontist. So I don't think that good relationship started on the right foot back then. So here's a question. You've talked about the Millennium laser technology and the LANAP, and you talked a little bit about LAPIP, the implant version of that. The question is, do other lasers have this kind of FDA acceptance for obtaining perio regeneration?
Right. So I can't speak to the actual FDA approval of those. What I have seen is that, as far as I know so far, this trademarked LANAP technique is the only FDA approved technique specifically for periodontal disease. Now, you can incorporate any of the other lasers for resective applications because they're taking the place of the scalpel. But I would encourage you to actually, when you buy the laser or work with the reps, they should be able to tell you. And I would be willing to guess right now, it's not an FDA approved periodontal protocol. Yes, you can use it as the scalpel for the resection, but I don't think they can make the same claims for, the same type of technology. Yes, if you use an ER YAG laser, you can resect and still, possibly get regeneration. It's just not FDA approved for that.
Okay, exactly. And this is again talking about case selection. And this question, when you're doing laser treatment, is it the same case selection as far as the number of bony walls will really be the determinant of your success?
Yeah, so what we're doing when we're incorporating this is that actually every periodontal patient that's either moderate to advanced or even refractory cases we're using as a first line. So every periodontal patient, we treat it regardless of bony wall defects. Now, the caveat to that is we'll tell patients, we can try to get some improvement in regeneration and stability here. There are some teeth that, as great as this technology is, it still has its limitations like everything else. And when we reevaluate things 12 months later, there still might be some teeth that if they don't improve, may need other treatment or removal.
Okay. And does mobility have any effect on laser treatment? Is that something where that might eliminate the indication for laser treatment?
So I wouldn't say that it eliminates the indication. One of the things I tried to illustrate a little bit in some of the cases I showed, and I didn't do maybe the greatest job with the splinting, was absolutely mobility does have a potential effect on regeneration and its success. If the tooth is mobile, it's not going to create stability for regeneration to occur. And so we try to account for that in the LANAP technique by splinting and using occlusal guards and creating stability in the teeth through our dental interventions. It's very important. That's also the reason why the occlusal adjustment is so important. The majority of teeth out of occlusion will be more stable to heal.
Okay. So regardless of whether you're going to do standard GTR or the LANAP technique, mobility is a complicating factor.
Absolutely. And you have to account for that with your recovery.
Okay, got it. Okay, here's a question about the occlusal adjustment that you discussed for LANAP treatment. Are you treating by quadrants or are you treating the whole mouth at one time?
So I appreciate that. I guess to answer that, I'll try to adjust what I think they're asking. You do treat the whole mouth, but you treat it over 2 appointments typically. So we'll plan the patient for a 90 to 100-minute visit for one side of the mouth. Then within a week or so, we try to treat the other side of the mouth as well in a short period of time.
I just have to commend the way you answer these questions is so crystal clear. It's incredible. This is just as valuable as your great lecture. The other question is, do you have any experience with this product, Perio Protect? And I know they make a pretty big play for general dentists, so I think it's important to let them know what it can and can't do.
Yeah, I appreciate that question about that. I do know Perio Protect is basically that product is like a tray system where the patients have these custom, they almost look like bleaching trays, only they're designed to extend down to the vestibule. And then you're putting this reagent into, I think it's like a carbamide peroxide, I believe. It's a decontaminating agent to use. And essentially what you're doing is you're trying to keep it there with some substantivity over the gingival crevices. And so it's designed to be used, I think, every day. And I think they would want to incorporate in conjunction with, of course, scaling, root planing, and maintenance, and all the other home care things. I know a number of practitioners that incorporate it and they think that it can be beneficial. I don't use it personally in my practice. I do believe that there is a place for it. It can work. But I would only venture to say that I would recommend it for patients that aren't willing to undergo the surgery, because now you have this patient that's doing this routine they have to do for at least 10 to 15 minutes every night, when we could create a more stable environment and then have the patient just do a good job with subgingival irrigation and interproximal care. So I guess I'm a little bit biased in my response to that. I do think it can work, but you have to remember this is something now you have to commit the patient to being compliant about doing every single day, in addition to everything else they're already doing.
Any idea of the substantivity of that reagent?
Well, I think with carbamide peroxide, I think it's only maybe a few moments. I don't know how good the literature is on.
So the trays try to keep it in contact for a longer period of time.
I'm trying to compensate for that.
And here's a great question that kind of sums up the problem of maintenance. I have an elderly patient with severe Parkinson's disease. She says she just can't maintain her teeth with her electric toothbrush any longer. She's basically given up on her home care. What should I try?
It's a great situation. I'd be curious about the dynamics with if there's any caretaking or not involved too, because we do have patients coming in with manual dexterity issues where they, if it's that bad for them, oftentimes they'll live with a family member. And so, or maybe a caretaker professionally comes to help that. So if possible, I'd love to try and, get the caretaker to come to the appointment. We'll try and do some coaching with both of them, say, here's some things you can do to support it. Of course, some patients don't have that dynamic. So, it's kind of hard with that, right? Because then the best you can do is maybe have them try to use some antimicrobial rinse. If you could try to get them on board with using a water picker, the toothbrush, just the best they can. Motivation is a tough thing. I would say maybe try and involve a caretaker or a family member at that point, incorporating some of these techniques.
Kevin, fantastic information, just really well presented. It's always fun to give somebody a huge topic and then only give them 45 minutes to present. It's a good way to find out what's really important and who can present what's really important. And you've done a brilliant job. So thank you very much. Thanks to the panel today, and thanks to all of you for joining us. And we'll see you next week, same time, when our speaker will be Dr. Justin Chi, continuing his discussion of digital dentistry. So we will see you then. Thanks, everybody. Thanks, Dr. Suzuki. Take care. Have a good week. Bye-bye.